Hey, so I'm consenting to be recorded. Hang on. There we go. So welcome everybody. Bienvenue tout le monde. On est très heureux de vous voir ici en si grand nombre. You are at the Global Primary Care webinar series, the second session today entitled Innovations in Extending the Delivery of Community-Based Primary Care. I am Marian Dove. I'm the chair of the Department of Family Medicine, and I'm here to welcome you to this webinar series, the second edition of this webinar series. This is a project that is jointly done between the Global Health Group in the Department of Family Medicine and the School of Population and Global Health. So I am delighted that this partnership is working out so well and that we are going ahead with this excellent webinar series, which started last month. So this series initiated last month, and it's a series of monthly workshops and invited speakers about the theme of global primary care delivery. And today's session is going to highlight innovative approaches to the delivery of primary care in local and global settings. And today we have two leaders of organizations that are trailblazing in the area of primary care delivery. Our first speaker, Rubaiyat Khan, is a social entrepreneur from Bangladesh who is currently CEO of Gion, a social business that digitizes and upgrades retail pharmacies in rural settings and connects them with doctors and hospitals in order to bridge the gap between underserved patients and quality healthcare. Next, we have Nan Chen from Last Mile Health, an organization that works to improve access to and the quality of essential healthcare for people living in rural and remote communities through teams of community and frontline health workers. And we have an extra special moderator today, who is Dr. Timothy Evans, who was our speaker at last month's webinar. Dr. Evans is the director of the School of Population and Global Health at McGill, and I am very happy to turn the talk the floor over to you, Tim, for the rest of the hour.
Great. Well, thanks, Marian, and thanks everybody for joining today for this second in the series. And in the first series, you heard from some people who gave a sort of a big global picture from 35,000 feet with respect to primary care delivery. In contrast, today we're going to hear from people who are right on the front lines and involved in innovating in really exceptional ways. So thank you to Rubaiyat Khan and Nan Chen for joining us. We'll begin with Rubaiyat, and I'll just provide a slight introduction to Rubaiyat to amplify Marian's. Rubaiyat is a serial social entrepreneur, a development practitioner, and a data scientist from Bangladesh, who's specialized in the innovative use of low-cost technologies to solve important global development programs. As a serial entrepreneur, he's been involved in a number of startups related to information technology and mobile telephony for development, and has co-founded a number of companies, the most recent of which is Gion. And Gion is, we'll hear more about that today, but is trying to leverage technology to upgrade rural drug sellers in Bangladesh. Rubaiyat is a graduate of the Harvard Kennedy School and with a master's in public administration. And he was awarded the Raymond Vernon Award for being the graduating student who best personifies the values of that program. And I think most interestingly on his resume, he's also an Unreasonable Institute Fellow. So with that, Rubaiyat, we'd love to hear your thoughts on Gion and leveraging technology to upgrade rural drug sellers. Welcome.
Thank you so much, Tim and Marian, for the warm invite. It is actually quite special for me to be invited to this because I was just reminiscing that back in 2002, I had applied to McGill and got rejected for my undergrads. So this is coming back full circle in some way. It's quite special that way. Give me 1 second as I tee up my PowerPoint. Can you see my screen? Awesome. Thank you. As was mentioned, I'm basically going to be talking about my experience working with the informal private sector of health providers, which I've been working with for the last 7 years in Bangladesh mostly. So please take my observations with a grain of salt, because this may not represent the global picture. I very much intend to focus on Bangladesh, but I do believe that quite a few of what I'll be talking about will apply to other contexts across emerging economies. So when we hear the word informal health provider, it might actually conjure up different images in our minds based on where we come from. So if we are from India or the Indian subcontinent, you might conjure up something like this, an Ayurvedic practitioner. You might, if you come from other parts of the world, you might think of shamans. And if you're from the great state of the United States of America, you might actually think of this. I kid you not, when I searched the word shaman on Google Images, this is what came up. So I couldn't resist the joke to a non-US audience. But joking aside, I think if I were to talk about who these informal providers are, the good news is that the informal sector around the developing world is increasingly dominated instead by someone who looks like this, a modern allopathic drug salesman who just happens to prescribe without training as a physician for lack of other options that people have in those areas. So just to put that in context, where they fit within the spectrum of formal to informal, on the extreme right, you have the formal sector, doctors, dentists, and nurses. You have right next to them, you have the paraprofessionals. And on the extreme left, you have the informal sector, Ayurvedic practitioners and faith healers. However, despite the fact that the Ayurvedic practitioners and the extreme informal still kind of by number, they're very large. But in terms of the popularity and the degree to which they reach people, village doctors are by far the most successful group among all, not just informal, but across formal and informal sectors. And by village doctors, I actually will interchangeably use pharmacists and village doctors, because about 82% of village doctors in Bangladesh, who can be both allopaths and homeopaths, but largely allopathic, they also actually sit in a pharmacy. So many pharmacists end up being village doctors and vice versa. So just to put some numbers onto this, in terms of density, there are 20 village doctors for every doctor or formal sector provider in rural areas in Bangladesh. They account for about 2/3 of the first point of care visits, compared to 12% for the formal sector. And in terms of out-of-pocket health expenditure, according to the national health accounts, they account for 70% of all out-of-pocket expenditure. So, and this is despite the fact, and this is very important to note, that this popularity is despite the fact that there's been decades and billions of dollars of investment in the formal sector and virtually zero investment in them as providers. So people cite a variety of problems to justify why they don't invest in the informal sector. And they, of course, do pose significant problems and challenges to work with. There's no denying that. Just to cite a few, they're highly fragmented and they're hard to reach. Regulation is virtually impossible because they're independent and almost invisible to the regulators. They lack training, therefore they often mismanage cases and practice irrational use of drugs. Historically, it's been quite difficult to get them to refer patients to the formal sector. And some recent research actually suggests that while training improves their quality of care, it does not really change prescribing behavior all that much. And that partly stems from the fact that they're perversely incentivized by the system to overprescribe and to prescribe high-end medicines. However, many of the challenges that you see here are actually more systemic in nature, so they apply to the formal sector as well. Just to give you an example, physicians have been found to be even more likely to prescribe antibiotics than village doctors for fever in several studies in Bangladesh. Pharma companies actually incentivize regardless of whether someone comes from the informal sector or the formal sector. So doctors are just as perversely incentivized to overprescribe, at least in Bangladesh. And it's actually been shown in literature that the quality of informal sector care actually closely correlates with the formal sector providers around them. So they actually learn and feed off of the formal sector practice that's going on around. Despite all of these challenges, though, they do have significant strengths that makes it imperative to at least consider them as an important part of the system. They're ubiquitous. They have a fixed address. They're a fixed facility. They're already self-sustaining, which cannot be said of many other providers. They practice modern medicine by and large nowadays and have the medicine supply linkages. They have deep expertise and knowledge about their communities, which many public sector or formal sector providers do not. They have massive reach and popularity, which was already mentioned before, and therefore they are a potent influencer of health decisions and expenditure for a large majority of the population. And I want to stress this last point around direct accountability, because this is often ignored. Because they're part of the communities that they serve, they are very highly accountable and they're highly visible to their communities. So just to give you an anecdote, during COVID-19, at the height of the pandemic in Bangladesh, hospitals had actually shut down and they were turning patients away. One of my own grandmothers-in-law actually perished after being turned away from 4 different hospitals on the street. And then the doctors were not really sitting in their chambers because the government was failing to provide them PPE support and other protections. However, we did a survey of pharmacies around June, and we found that 98% of pharmacies were actually open throughout that period. Their number of patients hadn't declined. People were actually going to them just as much. They were seeing up to 5 patients on average with COVID-like symptoms every day. So, they were doing this despite the fact that there was no training whatsoever given to them. There was no PPE support provided to them. GEON was the only organization that actually provided PPE support to about 2,000 pharmacies. And it just shows you that, like when we actually asked them why they did that, they said it's out of their sense of responsibility to their communities. But what they didn't probably say is that if they chose not to practice at that time and they were not beside their communities at that time of need, they would probably not have the same kind of reputation or kind of practice at the end of the pandemic. So they actually feared backlash from their communities as well. So given all of these strengths, we believe that it's almost unconscionable to ignore informal providers in health delivery, because that would mean basically condemning 70% of the population to low quality health services, essentially. So literature across what I've read over the years, if you look at all the research, you will read that they all end with a call to action, which is to acknowledge informal providers, to improve their capacity to engage with them constructively and to regulate them effectively. And yet, virtually every government in the world has at best ignored them and let them be, which is partly the case in Bangladesh. Or at worst, they've treated them as a menace, and that must be rooted out indiscriminately. And that's just not how this should be done, according to the literature at least. And we first got exposed to this space while doing research on how to improve rural healthcare back in 2013 as part of a previous business that I was a co-founder of. And when we realized that no one was actually doing this, despite the fact that it was such a huge sector, we almost felt compelled to explore this space and figure out a solution. So GEON's mission since then has been to upgrade pharmacies into an effective primary care delivery mechanism for these underserved communities that rely on them. So why is it possible for us to do, whereas it has been so difficult to do historically? I think it's largely because that the digital revolution has meant that a large segment of them, about 40%, are already digitized. They're using smartphones. And if we can aggregate these pharmacies into a digital platform and kind of overcome that fragmentation that they come with, that would allow us to connect them to training, products and services, and new technologies such as rapid diagnostics, telemedicine, or even AI-based triage, that would eventually upgrade them into better quality healthcare providers, or that is the opportunity that we're after. I'll talk a little bit about our journey very briefly before I go into our key lessons and takeaways. So since the beginning, GION's goal has always been to figure out a hook that attracts and onboards a large number of these dispersed pharmacies and village doctors onto our platform. And that has been key to our aggregation strategy, because that's the value proposition we want to take to government and other formal sector stakeholders like pharma companies. So we started in 2015, and initially we were operating a telemedicine platform that connected pharmacies with doctors in the city. And with that, we served about 10,000 patients. But in the process, what we learned was that it was very hard to scale, and scaling was crucial to our strategy. So we actually pivoted away from telemedicine in 2017 and launched what was a learn and earn platform, essentially a continuing medical education platform for pharmacists that also would add some commercial offerings over time. We got very high traction early on, but eventually we found that retention was an issue. We should have seen that coming. And eventually we could not find a path to monetization, even though the traction initially was quite high. So we pivoted yet again. And in 2019, we arrived at our current trajectory, which is a platform called GION Connect, which is essentially an e-commerce platform that connects pharmacies with their suppliers and top quality pharmaceutical manufacturers. And we're at about 2,500 pharmacies with them right now. So if it looks like we're fumbling around in the dark, that's because we probably are. So this is uncharted territory, and it's actually never been done before in the same way. And there was very little to almost none of existing knowledge and literature out there about what actually works in this space. So we are having to figure it out iteratively and by learning from failures. What I can assure you is that each of our pivots actually improved significantly on the weaknesses of the previous model, and each failure is generating new lessons about what does not work. So we've had some other accomplishments as well, which are largely from 2020 during COVID, because we had very aggressively responded to COVID using our network of pharmacies. So we actually trained over 20,000 pharmacies on a COVID-19 certification course. We built the largest online community of informal health providers in Bangladesh with about 25,000 active members. And we now have one of the largest databases of IHPs in the country with about 170,000 records. So those are some of the newer accomplishments that have happened when we had to kind of park our commercial trajectory and respond to COVID over the last year. So if I had to sum up our key lesson from the last 5 years, it would be that village doctors or the informal sector is, unlike many other kinds of providers, it's not really a blank slate that you can draw on. So what do I mean by that? They are operating within a very complex set of incentive structures. So just to oversimplify, pharmaceutical industry is continuously pushing products down their throat with various kinds of incentives, both legitimate and illegitimate. On the other end, from the demand side, patients and customers who are not particularly literate in terms of their own health, they're demanding quick fixes. So if a pharmacist actually refrains from giving a 4th generation antibiotic, the customer can just go to the next door pharmacy and get it because they need to go back to work the next day and they just cannot afford to wait. So that's a very strong incentive for them to overprescribe and to give very very potent medicines. And all of this is actually happening in a regulatory vacuum. So the governance system is completely broken. The policy does not even acknowledge the existence of informal providers, let alone provide a framework to govern them effectively. And in fact, even if there was policies, there would be no apparatus to actually enforce them, because the cadre of workers that actually are supposed to be auditing pharmacies in Bangladesh is only 50 people, whereas there are over 300,000 providers on the ground. So it's just never going to work. And of course, they are themselves busy practitioners, and it's quite easy for them to get away with mistakes. So how do you actually incentivize them to get better? So given that you cannot really change those existing incentives much in the short term, what can you really do as an innovator? Well, I like to say that you can play with what I call the 3 C's. And what those 3 C's are is cash or credit, which happens to be one of the fundamental pain points of any small entrepreneur, including pharmacists. They care about customers and sales, of course, because that's how they grow their business. And most importantly, this is something that's often quite ignored, which is the credibility factor. So when a pharmacist actually sets up shop, what they actually accumulate over the long term is the credibility as an asset. And that's what actually drives their patient flow, and the legitimacy and the reputation that they gain is what actually drives their business. So in terms of the financial benefits, you can provide loans, you can provide consignment models so that they don't have to worry about their inventory. In terms of customers, you can provide them marketing or branding support, loyalty solutions, or offer new products and services that they can sell to their communities. And in terms of credibility, you can actually offer them training and certifications. You can let them affiliate with well-known brands, or even get them government recognition. And all of this actually feeds into a very virtuous cycle. So if you can feed it properly, we believe that you can actually overcome some of the perverse incentives that they come with. However, it's very important to note that and this is my learning over the last 5 years, that initially my hypothesis was that you could actually do all of this digitally. But increasingly, I've realized that doing this purely digitally is often impossible. So you often have to have a hybrid approach where you have on-the-ground support and interventions, as well as a digital platform that makes the entire thing come together. So far, it might look actually quite straightforward, our lessons, but it's actually not quite so simple. And let me illustrate that with an example. So when we were running the telemedicine model, we think we did a pretty good job kind of boosting all of these factors, and we marketed to the community. We tried to get them new customers. We gave them training and affiliated them with brands, gave them government recognition. But what we realized after 2.5 years in the game was that every time a patient was coming in through the door, and the pharmacist would be required to actually kind of pass that patient on to a telemedicine facility, they were in fact acknowledging their own weakness as a provider. And that's obviously not good for someone who actually builds their credibility as a physician in that community. So what we were seeing was, despite all of our efforts, pharmacists were not really passing that many patients to us, to the telemedicine platform. Only patients that were walking in through the door, motivated by us, was actually getting referred. So that itself was a major learning for us, and we have kind of taken on lessons from that. I'll also share a case study of how the credibility factor alone might actually drive village doctors to do something very impactful. So this case is from the COVID era, the last few months, and this is from the municipality of Savar, which is in the vicinity of Dhaka. It's one of the peri-urban areas. And in a large municipality of about 7 million people, they had only 29 deaths compared to hundreds in a nearby and comparable municipality. And what was different in this community was that the local health officer from the government actually engaged about 2,000 village doctors, gave them training, gave them ID cards as first responders, and they were kind of mandated to do a few things. So provide primary treatment and counseling, record comorbidities, ensuring home isolation, bringing patients with them to the hospital whenever someone was developing kind of breathing problems, handling mismanagement, misinformation and rumors in the community. All of these things were their duties, and they were not really provided any financial incentives whatsoever. But because they were given an ID card from the government, And they were actually contributing to a major health crisis that would help them build their reputation in the community. They actually very actively participated and in fact invested their own money to distribute masks for free to the community and gave a lot of voluntary time to this initiative. And this is what the local health officer said later when we interviewed him. He said, all they want is respect. When we brought them into our program and recognized them, they eagerly helped and even invested their own resources. We were even able to develop mutual respect between them and the doctors, and they've been working closely together on many initiatives now, including responding to dengue fever and the flood. So that's kind of a healthy example of collaboration between the formal sector and the informal sector. We're actually learning from all of these experiences, and one of the concepts that we are really excited about going forward is a partnership that we've kind of created with the Diabetic Association of Bangladesh, which is one of the largest providers of diabetic care in the world. And what we're doing with them is to extend diabetic care to the last mile using village doctors. And the way we're doing that is by giving the village doctors an application that allows them to do AI-based triage, do rapid diagnostic tests using a glucometer or even HbA1c, refer to telemedicine or the diabetic center if any uncontrolled diabetes cases are identified, and to provide routine monitoring support and reminders to the patients. And the way this actually aligns the incentives beautifully is on the Diabetic Association front, they're able to cover the last mile patients at a very low cost and utilize their hospital resources better. For the village doctors, it's a matter of huge pride and credibility to associate with the Diabetic Association, as well as to serve a large patient population that previously they could not serve as well. And on the patient side, they're getting a 360-degree solution for their diabetes at the nearby and trusted providers. So this is something that we're actually launching, and in fact, we're applying to some research grants, including with Elena and her team, to evaluate whether this actually increases the rate of screening and routine monitoring of diabetes. So before I end, just brief on our longer term strategic direction. So right now we're focused on proving out these commercial models in Bangladesh. And we're also investing and partnering for research to generate evidence of what works. In phase 2, which should start shortly, actually, some of these activities have already started. We want to aggressively expand in Bangladesh and replicate the models to other countries. And in particular, we want to attract private investment and competition, because one of our core hypothesis is that the reason rural healthcare is really falling behind is because there's no private sector incentives in place. And the competition and investment that could come from the private sector could really amp up the game and create new innovative models for delivering healthcare at a low cost. We want to create a modular platform where other partners can offer their products and services. We are already in the process of building a coalition with innovators in this space to share knowledge and accelerate evidence. So similar to how Last Mile Health and others have worked on the community health worker model, we want to work on the informal health providers and generate similar evidence of success. And we also want to advocate with global development partners as well as national governments for favorable policy changes and additional investments in this space. So I'll end there. Please don't ask me very difficult questions because I'm closing midnight, but looking forward to your comments and questions. Thank you.
Thanks so much, Rubaiyat. Really refreshing to see how an invisible resource, which is massive, is made visible and then looked at as a resource for the system as a whole on chronic issues like diabetes and acute issues like COVID. So you've stimulated a lot of synapses despite the late hour in Dhaka, and thank you very much. What we'll do now is we'll move on to our second presentation. And just to say that the chats will be shared with both of our presenters, and we'll get to the question and answers as soon as we finish this next presentation. So our next presenter is Nan Chen, and he's the Managing Director of Health Systems at Last Mile Health. And Last Mile Health is an NGO that designs and builds community-based primary health systems with a big focus on the frontline health workforce. Nan is also a graduate of the Harvard Kennedy School, so I don't know if he overlapped with Rubaiyat, but he's also got a passion for working in entrepreneurial areas. He's a JD, which is a Juris Doctor, so I like a lawyer from Northwestern University, and also a BA from University of Chicago. He's the father of 2 children who are professional Zoom bombers. He gave us advance warning of that. And so, Nan, welcome. We look forward to your presentation.
Thanks, Sam, and thanks, Rubaiyat. You covered such good ground. I feel like there's going to be a lot of parallels between what I wanted to share. So in some cases, I might be able to go a little faster so we get to discussion. But the theme that you laid out, Rubaiyat, about moving from the informal to the formal, taking the things that are informal but working well and integrating them into the formal sector is kind of all about what I'll share. So let's move forward. So what are we talking about today? I think when we talk about things like scale or innovation, these are such ambiguous terms, and it's good to start defining our terms up front. And for us at Last Mile Health, a lot of what we think about when we talk about scale or innovation, it's really about adoption and adaptation by the public sector. For us, it's not so much about replicating our exact service or product, our exact geographic footprint, but really more about how we take the idea, the approach, and find adopters in the public sector. I'll talk today about how we think about that in Liberia, as well as I'll share a bit of a case study on that with regard to health worker payments. But to give you a little bit of background, let's start here. This is Jerome. He's my colleague in Liberia. He lives in one of the 15 counties called Grand Bassa. This is him showing off his supply of COVID-related face masks. Jerome's about 37. He's got 6 children, so 4 more than me. So I'm just waiting to catch up to him. And Jerome, as he grew up in Liberia throughout the Liberian Civil War, but then finished high school and became a community health volunteer around 2011. Then when Ebola struck Liberia in 2014, he also continued to volunteer and supported contact tracing and referred patients to care in rural areas. And in the wake of the Ebola epidemic, the Liberian Ministry of Health transitioned many of the community health volunteers, that informal workforce that like Rubaiyat was talking about, into a more formal, professionalized community health worker. And so he's part of that cadre now. Jerome serves his neighbors in the community that he works in, and it's part of Liberia's government program. So what does that mean to be part of that government program? Well, Jerome is trained. There's standardized training for all the community health assistants, and that's what they're called in Liberia, the CHAs. And he's getting trained in things like treating children for malaria, identifying the diagnoses and identifying where there are danger signs, similarly for pneumonia and malnutrition screening. And upon his completion of training, he's also equipped with medicines and supplies, as well as like smartphones and video lessons to help him keep up to date. Here, this picture, he's got his COVID-19 job aid, which I'll return to in a second. So he's trained, he's supervised. As he delivers care to his neighbors, he's got a clinical supervisor that is based at a clinic and then serves all the community health workers around that clinic, usually about 10 of them per supervisor. Jerome is also supplied. So he's got a stock of medicines and this is now part of the national supply chain. So on every routine supply chain visit from the national supply chain, they go stop by the facility, stop by the pharmacy, and then there's that last mile from the pharmacy, the local county pharmacy or district rather, to Jerome. And he's also salaried, which I'll be talking about in more detail today. But as part of the transition from volunteers to a paid community health workforce, Jerome is given $70 US per month for the work that he does. And I wanted to go back to this slide just to reemphasize one more time that if you look at this piece, the job aid that Jerome has, nowhere on this job aid does it say the words last mile health. And that's because when we think about scale or adoption of innovation, again, we're not talking about last mile health products or services. We're not talking about even scaling our own geographic footprint. We define success as government adoption and adaptation of that approach. So Jerome is one of roughly 4,000 community health assistants and supervisors in Liberia. And as part of that workforce, this is the 15 counties of Liberia. And if you look across 15 counties, last mile health in our directly, we're only actually managing directly in 2 or 3 of those counties. In the other counties, it's the same program, but it's implemented and funded by different donors, different NGOs, and in some cases, it's the government actually implementing. They're all getting the same salary, the same training materials, the same key metrics and outputs, and the same monitoring and evaluation system, but different donors and implementers. So I wanted to give you a sense of what scale looks like, or adoption to innovation looks like for an organization like ours. But then I think the really interesting part is how does this happen? So how does this happen? What on the right-hand side is what probably a lot of people think of in terms of, especially when you go to like TED Talks or things like that, what the world looks like in terms of scale. But what my life really looks like is on the other side, the squiggly, muddly line. It's completely frustrating on some days, but also incredibly energizing. So I want to give you a quick case study here using health workers payments as an example of this muddling through to innovation. So if you ask around, like, what is the best practice in terms of community health worker remuneration, the WHO actually explicitly says you got to pay the community health workers, and you should put them onto a formal contract. Some other best practices that I've heard will be like, let's get them on the government payroll so that they are consistently paid and that there is a long-term sort of domestic sustainability for this. And by the way, we've got this amazing M-Pesa system from Kenya. Let's get these guys on the government onto mobile payment systems as well. So you might, in terms of ideal technical practice or best practice, we'll hear things like these 4 ideas, but most of the time, the reality around the world and where we were in Liberia is this is not the way that things were working at the time. And the question is how you get from where we are to the world as it is to the world perhaps as it should be. And so, quick jargon alert, I'll use this definition for a moment and walk you through it. But I think this idea of muddling with purpose or iterating with purpose, I think as Rubaya was mentioning, is this active intentional process that help countries find and fit solutions over time, iteratively, that work in their context. And that by doing so, making those small jumps in iteration, build also political support and capability at the same time. So what do I mean when I say that? So let's start with your design space. And if you see here, just to point it out, on the bottom here, let's see, I don't know if you can see my pointer, you've got political support, political will. On the right-hand side are when you have everybody in the Ministry of Health and Finance and donors all agreeing this is a good idea. On the left is more likely the reality, most people would disagree. And on the y-axis here, you got systems functionality, which is a representation of, with the current capabilities when you're in your system, can you actually do this, or would this idea require something a little more sophisticated or advanced? So in 2014, again, let's talk about health worker payments. In 2014, prior to Ebola in Liberia, the existing policy was a policy of non-remuneration, meaning the community health workers were all volunteers. In some counties, an NGO would pay them sometimes $60 a month, sometimes $50, sometimes it'd be just a non-financial incentive. So there was a lot of political support for this because it's easy enough to, you don't have to stick your neck out to say, hey, we should pay these guys. It was also, from a systems perspective, pretty easy to implement because the Ministry of Health HR systems didn't have to do anything. They didn't have to put these workers into their payroll systems, nor did they have to register them. And if you ask, and this was the conversation at the time when we were first advocating for community health worker payments into policy, we should put these guys on payroll, we should get them paid standard, and maybe we should use mobile payments. Well, we would hear comments like, sure, that mobile payments might work in Kenya, but not here, not with our connectivity network. Or in Ethiopia, yeah, you can get a standardized health worker, but the government system there is so different than what we have in Liberia. We also heard that's a fine idea to, we understand about dignified work and all, but you'll never get the Ministry of Finance to agree to increase the wage bill, which is, our fiscal space is so constrained, we'll never get them onto payroll. That's not going to happen. We also heard that, our HR systems are barely handling the existing nurses and doctors on the registry right now. If we put another 4,000 health workers on there, we don't know how we're going to track all of them. So the result there is this leap from where we were today that was politically supported and capable within the institution, within the system, to something like this ideal best practice, this stylized best practice. It was just a leap too far. So what do we do instead? We experiment in hops. So where we started with was that, well, we couldn't get government, these community health workers on the payroll, on the government payroll, but we could find a way to contract them. There was enough political support to have a new policy of a paid cadre. We actually had to change the name from community health workers to health assistants because some folks thought that even using the word worker was a slippery slope on the government payroll. But they're contract workers now, and they have a formal contract with a standardized pay. And starting off with NGOs for execution of payment was a good compromise between overburdening the existing government HR system and just getting money into the hands of these folks. Shortly thereafter, over the next couple of years, some of the NGOs actually started experimenting with mobile payment pilots. I think what had happened was the fact that you now had these standardized contracts made it a little bit easier to think about how could we scale this up in a county with mobile payments, usually with a contract, with a partnership between a mobile network operator and an NGO, starting there. But that demonstrated capacity in managing payments is starting to build some of the other political will for later advocacy, like either expanding the mobile payment system or even getting some of these workers on the government payroll. Where we are now is some of their supervisors are actually getting onto payroll, and we're moving slowly in that direction. We're in the middle of it. It's still a really difficult political quagmire. And I think the point is that I'm not really actually sure what the next step, the next iteration might be. But with each successful hop, we're building a little bit extra political will. We're building a little extra capability. Every time you make a move, this whole design space shifts a bit, and it gives you new opportunities. So 3 quick concluding thoughts from me. 1, think in hops and leaps. Most of the time when you're building innovation or functionality in the public sector, you probably move in hops. But sometimes you might have leaps. This year with COVID-19 as a great example, there's a lot more movement on the political side for bigger ideas. And so you can think about those big ideas as well as how they might build on the existing capabilities that you have. Number 2, stay curious, build functionality, think about form and function. And in some cases, in a lot of cases, I think if you move a little bit toward the function, you'll open up more political space for different forms in the future. And lastly, be human. You are a human and you work with humans. Most of this work requires coalition building. And so try to create in mind the spaces for collective work, not just advancing your own institutional agenda. And especially in the example of payment, at the end of the day, we're talking about whether our fellow humans are being treated with dignity in the work they do. So every now and then come back and remember we're all people here. So that's it for me, and thanks for the time.
Well, thanks, Nan, for that superb presentation. And I think we've really been lucky to have two contextual areas to our context specificity, both Bangladesh and Liberia, with very similar but different approaches. And we had a series of alliterations from Rubaiyat related to the 3 C's of credibility and cash and customers. And then Nan decided to outdo Rubaiyat with an alliteration of S's related to scale, standardized training, supervision, supplies, and salaries. So with that, Brianna, do you want to just lead us to some of the questions? And if anybody wants to jump in viva voce, you're more than welcome.
Yeah, happy to, Tim. So we had a couple of questions, and I'll just start with you, Rubaiyat, if that's okay. So someone was wondering, you mentioned that the challenges are similar between formal and informal providers. So the problem of prescribing, over-prescribing versus incorrectly prescribing. This person was curious, is there any data that compares clinical outcomes between formal and informal providers? Wondering if you can shed any light on that.
I'm not aware of any that directly compare formal and informal providers, largely because it's probably politically suicidal to do that. Right. And the government actually hardly even acknowledges their existence, let alone allow a comparison between them and doctors. And in fact, in Bangladesh, at least, the medical associations have been extremely averse to any conversation about even training these providers, because they think of it as akin to teaching a thief to steal better. So that's kind of the language that's often used. Okay. So yeah, so short answer is I don't really know of any research that directly compares outcomes.
Perfect. And I suppose for this next question, you know, Nan, you can feel free to jump in too. It's a bit of a broad question. How can you incentivize referrals to the formal system? I know we talked a lot about the informal, but are there other ways that we can also apply those lessons to the formal system?
I can jump in quickly there. That's a really great question. And I think at the heart of what we are trying to do with community health workers in Liberia and a few other places, it is actually about integrating those two systems. So as an example, the community health worker like Jerome that I mentioned there, but in their protocol, it's they can, we can use malaria as an example. If they identify and diagnose malaria at the community level, they can treat it at the community level as well. But they're also on their protocol some danger signs. So if the fever persists, if it continues, then their protocol is actually to refer. So there's a change in process that's happening there. The supervisor that they have is in fact based at the facility. And so when he or she comes in to supervise every 2 weeks, he's asking Jerome, hey, what happened to that person you referred last week? Or are there any patients you have this week that are a little bit, showing you danger signs? And last thing I'll mention is there are like some also forms that you can bring in. So there's the referral and counter referral forms that we've tried, where you send the patient into the clinic with a form, they have to come back with the discharge form as well. And there's real challenges with I think follow-up and accountability sometimes here, but we're trying to figure out what are the process, the policy, and the cultural ways to move that referral question.
Great. Not sure if you
If
had anything to add. Yeah, go ahead.
Priyanka, can I add? Because the context is quite different with pharmacies in Bangladesh or British doctors, because there's no supervision. You cannot really hold them accountable because the only people they're accountable to is their community, and the community actually does not really want to go to the hospital for a referral. They want their solution right there at the pharmacy. So oftentimes the incentives are not really aligned for the pharmacy to be referring upwards to different facilities. What we're seeing though is that if it's very well defined for something that is very clearly out of their jurisdiction, or that they themselves know or the communities know is something that they cannot handle. So for example, surgeries for cataract or surgeries for cleft lip patients, those have, we've got good traction on those fronts. Diabetes happens to be something that pharmacists are actually quite averse to treating directly because they know a little bit about the longer term complications that can happen. Anything that can actually backfire on them in terms of credibility, so something they attempt to do and the patient actually gets worse, it's something that will come back to hurt them. You can, if you train them on all those possibilities of bad outcomes based on their treatment, that also can be a way to kind of incentivize referrals. So you have to play with that same incentive structure, but it's a combination of knowledge, incentives in terms of financial payments, as well as showing them very clearly defined boundaries of when to refer.
Great, thank you both for your answers. Tim, I'm just wondering, do you think I can squeeze in one more question? Yeah, okay, so maybe from both of you, maybe just a quick sentence or two. We have a question here. Given coalitions seem to be at the heart of your models and those of yours, can you recommend any successful models for coalition building, for building networks?
I'll defer to Nan on this one. They've been much more successful.
Well, success is in the eyes of the beholder, I suppose. Two quick thoughts, actually three come to mind. One, this isn't exactly a coalition model, but if you look at sector-wide swaps in the health sector, you can just Google that. It's like a health finance thing. But that idea of having the government lead one planning process where donors and implementers can all plug in, I think that type of coordination is quite, it's a structural and sort of architectural solution to this coalition challenge. But I think I've seen it seen some of it in Bangladesh as well as in Ethiopia, where that structure really tries to give a lot more of the power dynamic back to the government. So that's one, sector-wide swaps. Two, this is not health related, but there's an organization called Strive Together. I think they're US based. They have a collective impact model where they try to really create these communities of practice and coalitions at a city level. I don't know, I've only spoken to them a few times, but I think there's something there about thinking about collective impact in the terms of almost like decentralized leadership within a local level. And then lastly, one thing that's more at a community of practice level, there's an organization called the Community Health Impact Coalition. And we're part of, Last Mile is a part of it. We're a group of organizations that kind of have a similar set of principles in terms of community health practice. And they're doing a really good job of sharing information, sharing best practices, and trying to kind of hold each other when we're going through the muddling policy processes.
Perfect, thank you. So I suppose I'll turn it back to you, Tim and Marian.
Great. You want to say something before I
I'm not sure if it's me or if Tim is having internet problems. I'm hearing only part of Tim.
Yeah, it's a little choppy on my end too.
Marian, we can hear you better than them.
So let me, if people can hear me, it's not on my end, I want to thank both of our speakers. Those were fascinating talks. And as we already discussed in the question period, that they had many overlapping features, and it was very interesting to see the perspective from Liberia and from Bangladesh about the importance of the relationship with the community and with individuals. And I was thinking to myself as all the questions were being answered about the parallels with family medicine, where the doctor-patient relationship is really the cornerstone of family medicine, and how in both countries, the examples that you gave of the community health workers who are really embedded in the communities and who are trusted by the people really are the most effective. So I just thought that was another interesting parallel to make. Tim, I see that you are back now. You were chopping up for us before. So I just want to reiterate from the Department of Family Medicine, a thank you to both of our speakers today. It was wonderful to have you, and I'll turn it back to Tim for some final words.
Great, thanks. And sorry, clearly the bandwidth was so overprescribed by your presentations that I lost connectivity. So testimony to stimulating the synapses, especially Rubaiyat at this late hour. So tremendous session. I just think that the discourse here, and I appreciate the work that you all are doing so much, but the discourse more generally that we need to be promoting is that no system anywhere can be without a vibrant front line. And if we don't have that vibrant front line, it's a threat. We're going to lose connection with community. We're going to be less able to respond to pandemics. We're not going to be able to deal with chronic diseases. So in some respects, I think these innovations that both of you are pioneering from a private and public sector perspective on the front lines are so essential to every health system in the world. So I just want to thank you for sharing those insights, congratulate you on your fine work, and ask others here to continue to join us in this seminar series and presentations to really think outside the box in terms of how we're going to do better, because this discourse, I think, is really so important to every health system everywhere. So with that, just a little bit of shameless advertising. On Wednesday, the 24th, that's a week from now, we'll have a workshop series where we'll have a little bit more time to discuss these issues, and then we'll have a third seminar in March on the 17th, and we invite everybody to join on that front. So thank you everybody for your participation today. Thanks to Brianna for setting things up, Marion for accommodating an inferior moderator, and to our two presenters, Nan and Rubaiyat, absolutely superb and very, very grateful. Rubaiyat, we hope you catch up on sleep, and Nan, I don't know how you managed those Zoom bombers, but I didn't see them. So thanks for that. Bye, everybody.
Thanks.
Thanks, everyone.
Hey, Brianna.
Hi there.
I have to get on another call. But wasn't that interesting?
That was so interesting. Oh my gosh. I really enjoyed that.
No, I mean, they're both, I mean, isn't Rubaiyat, he's absolutely fascinating.
Yeah, it was a good recommendation, both of them.
What he's doing, I think is, well, obviously I'm doing some research on it. So